So welcome to our study group. Again, we are doing part 2 of the 50,000 series with the reproductive systems and then also maternity and delivery. So I promised last week there would be a little bit of an update on question number 5. So question number 5, we had decided for sure that the code that we needed was 50220. And we were I was in debate with myself, I'll be honest, whether or not the code for the inflammation. So the way that we're going to find that, we knew that our glomerulosclerosis code was the N26.9. Because once we go to once we go to glomerulosclerosis within the alphabetic index, it tells you to look at sclerosis and then renal. And then that takes us to the N26.9. Now, for again, the inflammation of the kidney, the renal pelvis, and the ureters, we would go to inflammation for main term. Underneath main term inflammation, we will look for the ureter. Okay. So we can look for kidney or we can look for renal pelvis. And then let's take a look and see what those end up showing. And I guess let's look at this from a testing perspective. Okay. So really in the real world, your inflammation of the kidney is going to have a separate code. Okay. Your inflammation of the renal pelvis and the ureter are going to have their own code. Okay. So in this scenario, from a testing perspective, we really are only coding the inflammation of the ureter because we don't have an option that includes glomerulosclerosis, inflammation of the kidney, and then inflammation of the renal pelvis and the ureter. Okay. So if you run into a scenario like this in your testing, practice exams, whatever it may be, then we just want to make sure that we're just coding whatever's the most accurate option from a testing perspective. Okay. Now, if you go to inflammation, and then there's actually not a ureter. Okay. So what we need to do is think, what is the medical term for inflammation of the ureter, right? So medical term, our suffix is itis, right? So that means inflammation. And then ureter is a pretty simple, med term because it's just ureter. So we're going to look up the medical term ureteritis. Okay. And then underneath ureteritis, then you can either go with the default code or there's a non-specific entry, and that's going to give you the N28.89. And then again, just make sure you always verify it in your tabular. So N28.89, that actually does include the inflammation of the kidney as well as the ureter. Okay. So actually, in the alphabetic index, it would send you in a different direction. Okay. But once you were to look at your N28.89 for that inflammation of the renal pelvis and the ureter, underneath the ureteritis, and we verify our code. So this is a pretty good example of why we want to make sure we do verify those codes in the tabular, right? Because we could potentially end up coding something separately that should all be included in a single code. Okay. So for this one, N28.89 is going to signal our inflammation of the kidney, the renal pelvis, and the ureter. The N26.9 is going to be, again, for that glomerulosclerosis. And then the 50220 is going to be for that nephrectomy with a partial ureterectomy. And then we have that LT modifier, right? Because we ended up doing it on the left, right? It was the left flank nephrectomy. So any questions on that one and the clarification, just real quick, from last week? Okay. So now let's shift gears and talk about maternity and delivery. Okay. So number 6, we have Mrs. Jones, which is G1P0, is diagnosed with polyhydramnios, and she's scheduled for an amniocentesis to aspirate some of the excessive fluid from that amniotic sac. The amniocentesis is then performed under ultrasound guidance. So what code or codes should we report for the procedure? So what in the alphabetic index in our CPT manual, what is our procedure, or what is the main term that we want to look up if we're coding this from scratch? Yep, amniocentesis. Perfect. So underneath the amniocentesis main term, we have a couple options. Is our amniocentesis that we're doing, is it diagnostic? Is it for an induced abortion, or is it therapeutic?
Diagnostic?
Yep. No, nope,
How?
nope. Sorry, I got excited about. No, it's not diagnostic because we're actually removing fluid. Okay, so we're actually performing a procedure when we go in and do. So we're not just pulling out just a small amount of fluid to do like a diagnosis or an analysis on that fluid. We're actually pulling out I don't want to say significant amount, right? But we're doing more of a procedure for a therapeutic purpose versus finding out what's wrong. Okay. So we will go with therapeutic. Yep. And then it's 59001. So let's just go look at the code description so that way we can get familiar with how some of those codes read. And then your 59001 is your amniocentesis for therapeutic amniotic fluid reduction. Okay. So should we also code our ultrasound guidance separately? Okay. Why
Nope.
would we not, Sylvia?
I said yes. I'm sorry.
Okay. Xenia said, okay. So Xenia
I
said
said,
yes.
oh, no,
Sylvia in the
yes.
chat said no. Yep. Because it's all included.
Oh, it's
Okay.
include, yes.
Okay,
Yep. Because
gotcha.
if you look at your code description, it says include your ultrasound guidance.
Okay, gotcha. So we won't need
Yep.
the ending. Okay, gotcha.
Yep. So if we
Got-
were to report that ultrasound guidance separately, that would be considered unbundling. So we would
Okay,
get paid
gotcha.
for that ultrasound guidance twice.
And that will be right. Okay, gotcha.
Yep. Yep. So just kind of keep in mind because they will give you an option if you have a scenario similar to this. They will more than likely give you an option to
The
have
code.
just the procedure or the procedure and that ultrasound guidance separately. So just make sure that you're not just going, oh yeah, they need ultrasound guidance. There's a 70,000 code. I need to pin that, right? Make sure you're reading those code descriptions fully for sure.
Okay, 'cause if it
Yep.
says included, then you don't need it. Okay, got it.
Yep. Yep. Because let's think about it. Let's think about it in more of a procedure standpoint. If you have, if you're having that procedure done, right? You're hoping that they're not just going to go in willy-nilly with a needle and just kind of just start stabbing and not know exactly where they're going, right? So anytime you have that amniocentesis done, then it should be done under that ultrasound guidance so that you can guide it and it doesn't go too far. You're not missing the amniotic sac, whatever it might be. Okay. Number 7, patient has a LEAP conization for CIN2. So here we have CPT codes and ICD-10 codes. So let's look at this one from a testing perspective and process of elimination. So how do you guys want to do your process of elimination with this one? Any thoughts? Okay. So yeah, let's do ICD-10. So the way that I would do it is find the options that have, or find options that have something in common, right? So we can either confirm or deny, or not deny. We can either confirm or rule out. Okay. So I would look at N87.1 because it's in A and C. Okay. So we can either confirm it should be A and C, or we should be able to rule out and say that it's not A or C. So N87.1, your official definition is moderate cervical dysplasia, but then underneath that, it does have that includes the little note that has your cervical intraepithelial neoplasia 2, or that SIN 2. Okay. So we know that N87.1 is our valid ICD-10 code for this scenario. Oh, I don't know what just happened there. We know that that is our valid ICD-10 code. I don't know if I said CPT or ICD-10. It's our valid ICD-10 code, so we can rule out B and D. And then we just need to pull out our CPT and look for 57522. See if that matches our description for LEAP. So 57522 is for a conization of the cervix with or without fulguration, with or without dilation and curettage or DNC, and then with or without repair, and it's done loop electrode excision. Okay. So if you're not sure what LEAP stands for, and you're not 100% sure that that loop electrode excision is going to be the same thing as a LEAP, go look at your 57461. Let's go look at that and see if that will give us any more indication of what it should be. So 57461 is a colposcopy of the cervix, including the upper adjacent vagina, and then with loop electrode conization of the cervix. So which code do you all think we should code? Okay. Myra says A. So 57522, which is the conization of the cervix with or without the fulguration, with or without the DNC, with or without the repair. Okay, so Myra, is it Mayra or Myra? I don't want to say it wrong. So you're changing your mind. You're saying
sorry,
it should
yeah.
not be A.
Yeah,
Okay.
I meant C, and it's
Okay,
Myra.
no, you're fine. It's Myra. Okay, so I
Yeah.
was saying it right.
Thank you.
Okay. So everybody thinks it should be 57461 for the colposcopy. Did we have any indication that we did a colposcopy in this scenario?
No, it should be A.
Yep, it should be A, because A is only saying that we did a conization that was done by loop electrode excision, where the 57461 is saying that we had the loop electrode conization of the cervix, but we also did a colposcopy. Okay. So those are going to be two separate procedures. So we should make sure that we're not just matching the part that's in the indented portion of the code, right? We have to make sure that we're matching the entire code description, which includes that common portion of the code that's before our semicolon, right? So again, our 57461 describes only the conization. Now, if we had done a DNC, if we had done a repair, or had we done fulguration, it still would have been the 57461. But because it says with or without, then it means if we did it, great, it's all included. If not, it's totally fine. We're still just going to use this code anyways. Does that make sense?
Tiffany, what does the LEEP stand for?
It is loop, electrode, excision, and then the P is, let me look it up because I don't want to say it wrong.
If you didn't know how, you know what it,
Procedure.
where would you look that? Would you look it up under the tabular? As far as,
You can, yeah,
okay,
yeah, you should be able to look it up under LEEP, LEEP in the abs or in the alphabetic index.
okay, I'll put it- okay.
Let's look real quick and just see. I think it's under LEEP. Yeah. Yep, LEEP procedure, and then you have either a conization or an excision. Yep.
Okay.
Yep.
Thank you.
You're very welcome. Okay, any other questions on number 7? Again, just make sure that you're only coding the procedures that were done. I know sometimes it's super easy to just go straight to that indented portion of the code, and just say, yep, that looks like it's it, right? But it's very important. And I don't know if everybody has their books prepped, but it's always nice to have all of those families grouped together, and have like a little circle. I always call it a little fence because we're keeping the kids with the parents and we're keeping the family together, right? So it's always nice to just kind of have a visual representation to show you where that parent code or that main code is, the main portion of the code up at the top. Just kind of have some type of visual, whether it be a bracket, whether it be a little circle or a box, however you want to do it. I always tell my students to do that. So that way it's very easy to tell where your parent portion of the code is, and you don't have to if you prep your book ahead of time, it's a lot easier for your mind to not play tricks on you during the exam because you've already done the hard work of doing, finding where all of that information goes together. Another quick tip that I've had a lot of conversations about in the last week or so is on your resequenced codes. I know sometimes it takes me forever to find a resequenced code. And if I'm looking for a resequenced code, I don't want to take too long to do that during the exam, right? So if you take the time ahead of time, or ahead of, your exam, and prep your book and number the page where that resequenced code is now found in your book, then that will cut down on stress, anxiety, frustration during the exam. If your eyes start to kind of cross and you can't figure out what page it's supposed to be on, if you already have that page number there, the worst you're going to have to do is figure out where it's at on the page, and not flip back and forth and get frustrated because you can't find that code. Okay. So that's just another quick book prep tip for you. Even if you don't prep a whole lot with it, just do those 2 things, and that will really help your eyes kind of draw to where they need to be very easily. All right, number 8, we have a 23-year-old woman that presents with sudden left lower quadrant pain, which does not resolve. The decision is made to perform an exploratory laparoscopy, and that reveals a cyst on the left ovary. The cyst is then removed along with a partial oophorectomy. So what is our CPT code or codes for this procedure? So let's look at this one from a coding from scratch standpoint, okay? So if we are doing an exploratory laparoscopy, and then it results in a procedure, do you think we should also report that exploratory laparoscopy with the procedure, or do you think it should be one or the other? Okay, only one. Which one do you think it should be, Sylvia? Do you think it should be the exploratory laparoscopy, or should it only be the cyst removal with the oophorectomy? She says, I don't know. Okay, so Myra thinks it should be the laparoscopy. Okay, So let's go look at, in the alphabetic index, let's go look at laparoscopy, okay? And let's just kind of do a little bit of searching, looking at guidelines and kind of talking this one through, okay? So if we go to laparoscopy, and then underneath abdomen, right? Because that's where we're going, is we're going into the abdomen. It's the left lower quadrant. And then diagnostic, our CPT code is going to be 49320. Okay. So let's go look at our CPT code 49320. So when we're doing surgical laparoscopies, well, in this case, we're doing an exploratory laparoscopy, right? But then it did convert into a procedure where they removed the partial oophorectomy, right? So if we are doing a diagnostic, so think of exploratory as the same as a diagnostic, right? Because they're going in, they're trying to figure out what's wrong, right? They don't have, they have an idea of what it could be, right? But they don't know. So they're not going in with the sole purpose of performing a procedure, right? So if they're going in for an exploratory laparotomy or laparoscopy, sorry, a laparoscopy, at that point, we can have, it says surgical laparoscopies always include your diagnostic, but in order to report a diagnostic laparoscopy, you can use 49320. Okay. So with this one, hang on, sorry, I'm trying to make sure I'm saying this right. With this one, it should. Yes, sorry, I was reading the answer key wrong. I was reading, in my head, I was reading that it was letter C, but it's actually letter B. Okay, sorry. So for this one, since we went in for the purpose of doing a diagnostic, and then we ended up doing a procedure, then that surgical procedure is going to include the diagnostic procedure, right? So we should not report the 49320. So from a testing perspective, we're still already ruling out 2, right? Because we know we should not report the 49320, which is in A and C. So then in our alphabetic index, because we're going to go back to doing this from scratch now, so we're going to kind of switch back and forth on this one. We're going to go to, let's see, we did a cyst removal along with a partial oophorectomy. So let's look at the code for the oophorectomy, just because that one's probably going to be a little bit easier to find in the alphabetic index real quick. So let's find, if my eyes will not play tricks on me in my alphabet today. Okay, so in oophorectomy, again, we're doing it laparoscopically, right? So make sure that you still pull in that laparoscopic component of the exploratory, because they didn't say we converted it into an open procedure. While they were in there doing the laparoscopy, it revealed a cyst, and they went in and removed it along with part of the ovaries, right? So oophorectomy and then laparoscopic, and that gives us 4 codes that we have to look at, right? 58548, 58552, 58554, and 58661. So let's look at the 58548 first. Just kind of go down the list, just like we didn't have questions in front of us or the answers in front of us. So 58541. That is a laparoscopy, surgical, supracervical hysterectomy for a uterus. Is that the right code? Hang on, let me make sure. 58548. Sorry, not 1. 58548 is a laparoscopy surgical with a radical hysterectomy with bilateral total pelvic lymphadenectomies and a para-aortic lymph node sampling or biopsy with removal of tubes and ovaries if performed. So we didn't do 90% of what that code says, right? We didn't do a hysterectomy. We didn't do a lymphadenectomy. We didn't do node sampling, and we didn't remove tubes. We only did a partial oophorectomy. So the 58548 is not it. 58552 is a laparoscopy, surgical with a vaginal hysterectomy for a uterus 250 grams or less with the removal of tubes or ovaries. Again, we did not do the hysterectomy, so it would not be the 58552. 58554, same thing. It is laparoscopy, surgical with a vaginal hysterectomy for a uterus greater than 250 grams with removal of tubes and ovaries. So it's not that one. And then 58661. And that is a laparoscopy surgical with removal of adnexal structures, which include partial or a total oophorectomy and or salpingectomy. So that is going to be our code for the partial oophorectomy. So think about this. Should we also code the cyst? Why are we, I guess we know that we're not, right? Because we know that B is the correct answer. But why are we not coding the removal of the cyst on the left ovary? Any thoughts?
Because
Is
we're
it-
removing our ovary.
Yep. Yep. So it's kind of like if we're doing a biopsy on the skin, right? If we're doing a biopsy on the skin, but then we do an excision of that same area at the same time, we're only going to code the excision code, right? Not the biopsy. Here, same thing. If we're removing a cyst on the left ovary, but we still did a partial oophorectomy along with the removal of the cyst, then that's going to be included and it's going to only be that one code. Does that make sense? Okay. Number 9, patient presents to, or a pregnant patient presents to the hospital in active labor. The obstetrician providing her prenatal care is contacted to perform the delivery, and the provider delivers twins vaginally. The OB will also provide the postnatal care. So what CPT code or codes should we report? So a twin vaginal delivery. So we know, and with the alphabetic index, you really only have a couple codes, right? When we're talking about delivery codes. So you have in your CPT, you've got a section that is labeled maternity care and delivery. If you're in the 2024 CPT book, it's on page 450. And it starts with code 5900, or I'm sorry, 59,000. So 59000. So if you're using 2023, just look for the CPT code 59,000, and that will start your maternity care and delivery. So if we have an obstetrician that is doing prenatal care, the same obstetrician is providing the delivery for the twins. And then they are also expected to provide the postnatal care. Okay. What global package, or do you think we should use a global package for the twins, or do you think we should use something else? So when we look at vaginal delivery, right, because we know that these are both vaginally, okay?
We-
If we look at the codes for a vaginal delivery, you've got 59400 through 59430. Actually, no, 59400 through 59410. So those are, you only have 3 codes technically for vaginal deliveries. Okay. Everything else that's in that section is for your antepartum and postpartum care. So with our 59400, that is considered our global OB package for a vaginal delivery. And then 59409 is the vaginal delivery only. And then 59410 is including your postpartum care. Okay. So since they did all 3 components, they did prenatal care, they did the delivery, and then they did the postnatal care. We know that we at least need to use one global 59400, right? Because we did have a full global package for one. Now, the way that insurance looks at it is when you're pregnant with twins, you're not going to have double the prenatal care and double the postpartum care, right? You're going to have the same amount of visits. You might have a little bit extra with twins for the prenatal care, but you're not going to have anything significant to be able to say we need double the prenatal and double the postnatal pay, right? So when you have twins that are delivered vaginally, you should report baby A that comes out vaginally with a global package. And then baby B is going to be the delivery only. To just say, we're not using the global package for baby B, but we should get paid for the delivery because we were present for the actual delivery itself. Okay. I'm going to throw a kink into things. Okay. What if you were to have one vaginal delivery, and then after that first vaginal delivery happens, multiple things can happen, but the mom is rushed in for a C-section for baby B. So if we have twins again, okay, baby A is vaginal, baby B is C-section for whatever reason. Like I said, that can happen for multiple reasons. Baby A can come out, baby B then says, oh man, I'm not scrunched in here anymore. I've got all the room, and they start doing flips and turns and all the things, right? The cord can get wrapped around baby's neck. So then that could lead for a C-section. Mom's blood pressure could drop or skyrocket, either one. Exhaustion, whatever it might be. Okay. So baby B, they then take them in for a C-section for baby B. Okay. So JD says we would report 59514. Okay. So you think that we need to have a vaginal, we need to have vaginal global package for baby A and then just the C-section for baby B. Is that what you're saying, JD? Okay. So it's actually the opposite. Okay. So if we think about global packages, if we're having a vaginal birth, then we're really only going to have like maybe 1, maybe 2 post-birth, post-delivery follow-ups, right? But whenever you have a C-section, they're making an incision, they're cutting through all the layers, they have to do the incision check at the end, right? Not at the end, but like a couple weeks after delivery. And then they have to do another, just to make sure you're healing correctly. Okay. So your global delivery is actually going to go on baby B. Okay. So that's going to actually be a 59510 for baby B. And then baby A, we're going to say we're only doing delivery only. And then that's going to be a 59409 with a 51 because it's multiple procedures. So, yeah. So it's one of those things that, so Dawn, if we had two twins that were both delivered C-section, that's a different scenario. I'll go over your answer in a minute because that's kind of right, but technically not right at the same time. And I'll explain why in a second. So you would do, again, your global package for baby B for the C-section because it's the more intense, it's the more complex procedure, right? And then you would do your vaginal delivery only for 59409 with a 51. Does that make sense? Any questions on that one? That can be a little muddy and a little complicated.
So you don't, Tiffany, you don't then code the global package in for this first child, being that you did that for the second child. Is
Right,
that what
because you don't want to do two global packages, right? Because you're
You
not
can't.
going to get paid for twice the prenatal care again and twice the postnatal care again, right?
even though it's different,
You want
it
to
was a
do,
different delivery,
yeah,
different type
Yeah.
of delivery, I should say. Okay.
Yep. Okay.
Mm-hmm.
So then let's say we have, and the same thing goes for if it's a VBAC. Does everybody know what a VBAC is? The vaginal
No.
birth after cesarean. So if this is mom's second pregnancy or third or whatever, it's just not her first, and she had a C-section on a previous pregnancy. Okay. A lot of doctors will not want to let mom try to have a vaginal delivery after you've had a C-section because there is the risk of the uterus splitting open where that scar tissue is from the previous C-section. Okay. So a VBAC procedure or a VBAC delivery is going to be a lot more intense and a lot more complicated. So you have what's known as your VBACs, and those are going to be coded with codes 59610 through 59622. So those are your delivery after previous cesarean delivery. Okay. So if you have a successful VBAC, then that means that we were able to push the baby out of the birthing canal and it comes out the vaginal area, right? If it is unsuccessful, so mom attempts it or she goes into labor, right? And then doctor says we have to stop it because of blood pressure, because of stress on the uterus, the baby, whatever it could be. And they decide to go in and do a C-section. That's known as a failed VBAC or an unsuccessful VBAC, right? Because we tried to do a vaginal delivery, but it was unsuccessful. Okay. So that's the same thing goes, the same concept goes with this. If you have twins, you can do a VBAC with your first baby, right? With baby A, but then for whatever reason, either it's physically impossible, the doctor doesn't want to chance it, whatever it is, they go in and do a C-section for baby B. You would do your VBAC delivery only, which would be 59612 for baby A, right? And then you would do your unsuccessful, I can type tonight, unsuccessful VBAC, meaning that we did a C-section again, and that unsuccessful VBAC is going to be the global unsuccessful VBAC. So it's an attempted vaginal delivery after C-section and not a successful. Okay. So this would be 59618. And then as always, we should put the 51 on baby A because it's at multiple procedures. Does that make sense with the VBACs? So same concept. Baby A's vaginal. It's just a matter of whether there was a previous C-section. Okay. Any questions on VBACs or twins that one is vaginal, one is not vaginal?
Sorry, really quick. You said baby A is 51, right? You add the 51.
Yep.
For the answer B, so is baby A the 409?
Yeah, for this one, because they were both vaginal. So this is
Oh,
twins
gotcha. Okay.
that are one vaginal, one C-section.
Okay.
So this is still, either way, it doesn't matter, right? Because they're both vaginal, so it doesn't matter, right? Because either one, it could be baby A or baby B, right? It doesn't really matter because it's the same method of delivery, right? The only
Okay.
reason it matters with your vaginal and your C-section is because you've got different methods of delivery here,
Right. Okay.
right? Okay.
Thank you.
I know pregnancy and delivery is a whole different ballgame. Okay. So let me talk about if you have twins and they are both C-section. Okay. Both C-section. Okay. So when we think about a C-section, right, we have the same incision. We only make one incision, right? We don't make multiple incisions for twins. We don't say we're going to take one out on the left and one out on the right. Usually they'll just make that transverse abdominal incision, right? And they will take the baby, both of the babies or multiple, it could be triplets or quadruplets or whatever it is, right? If they take all of them out in the same incision, which they do, then technically you could say baby A is going to be your global C-section package, okay? Which is going to be global C-section is 59510, okay? And then baby B would just be a C-section delivery only, right? That's kind of what your brain's telling you, right? Because that's what we've done with all of the others.
Mm-hmm.
Well, insurance will more than likely deny. Let me find your code for the C-section delivery only real quick. 59514. I can put it on here. Insurance is more than likely going to deny your baby B portion of the claim because they're going to tell you you're not going to have multiple incisions. It doesn't really take a whole lot of expertise. Baby B usually comes out 20, 30 seconds after, right? So there's not really a whole lot of effort that goes into prepping mom for the delivery only of baby B. You know, she's not getting twice the anesthesia. She's not under for a super long time. It's not like extending the time a whole lot. Might extend it a couple minutes, but the expertise, again, they're not doing additional incisions. They're not doing additional closures, right? Because the closure would happen whether baby B was present or not, right? The incision would happen if it's a single baby. The closure would happen if it's a single baby. So if they're just doing an additional delivery of that baby through the C-section, then there's not really enough there to qualify to bill that separately for an additional C-section delivery only. Does that make sense?
Mm-hmm.
While coding wise, this would be correct. But insurances typically will say that you should only bill one global C-section.
For both
Because
babies.
there's not enough, there wouldn't be enough like work put in to count for a second delivery. Make sense? Any questions? Like I said, I know pregnancy can get a little muddy, especially when we start talking about twins and then VBACs and regulars and C-sections and all the things, right? Because you would think that, hey, we're just giving birth, right? But kids throw a kink into everything. They always make it messy, right?
So if we had this scenario in a question, then we would then just code the 59510 then as the answer versus both of them, correct?
Yes, more than likely from a testing perspective, they would have you only code the 59510 because
Okay.
that's a pretty general standard practice for Medicare, Medicaid, a lot of your commercial plans, right? So I don't think I've ever seen them ask for a 51 with a delivery only for a C-section
Okay.
on any of the types of questions that I've ever seen. Now, it doesn't mean that they're going to like totally throw something in and throw a kink into things. They might throw in, you know, a 59510 times 2, which wouldn't be right, right? They might throw in a 59510 and then a 595. I'm just thinking of what else they might throw in, a 59515, you know, just to see if you're paying attention, you know, to whatever it is, right? But from a testing or from a real world perspective, at least, twin C-section, you would only code your global C-section for baby A. Clear as mud. Okay. I would, if I were you guys, I would definitely either take a screenshot of this, or if I've seen Dawn writing down a little bit, but write these scenarios in your book, right? Again, I'm going to take this out so that if you do take a screenshot, you don't copy the wrong thing in. Another thing too, this isn't just for twins, okay? If you have multiple gestations whatsoever, right? So then let's say we have the same thing and we have triplets, okay? We have 2 that are vaginal and then 1 that's C-section. Okay. We're going to again do baby A as a vaginal delivery only, right? We're going to end up putting a 51 on it because we know that it needs to have that 51. Okay. We have baby B. That's a vaginal. We're going to do again delivery only. We're going to do 59409 with another 51. Okay, because we can bill for the vaginal deliveries for each of the multiples. Okay, and then we would have baby C, which is the C-section.
That'll be global.
That would be the global OB, yeah, or that would be the global C-section package.
Okay.
Which would be your 59510.
Because that's more intense versus the vaginal, is that right?
Yep, that's exactly right. So it depends on, and then same thing over here. I'm not going to write it out for VBACs, right? But it's the same thing. If you have triplets, as long as they're not all C-section, right? As long as you have multiple different methods of delivery, then you can do your global package for 1, whichever is the most intense, and then your delivery onlys for the remainder of the ones that came out vaginally for multiples, right? Okay. So I just wanted to kind of point that out too. That's not just for twins that you can bill for multiples. You can do it for triplets, quadruplets, quintuplets, like all of that kind of stuff. But with your twins or even multiple gestations, if they are all C-section, then you would only bill a single global C-section package. Some of your insurance companies might let you put a 22 on it for increased procedural services if there's a large amount of multiples, right? But they're not going to let you do it for 22. If it was like 4, 5, 6, maybe, they probably would let you do it. You would just have to make sure that it is documented and it is supported and it's good. You might have to fight for the payment a little bit, but most of your insurance companies, if you say, hey, they had quints, right? It's not just like we're taking 1 extra baby out, we're taking 4 extra babies out. So that might include that, depending on the payer, they might say, yeah, you're right, it does warrant a little bit extra payment type thing. So just keep that in mind. Okay.
Tiffany, one other question.
Yeah.
With the baby A and B with the triplets, would they
Okay.
have it laid out as the 59409 dash 51 times 2.
You could do it either way. Yeah.
Okay.
Yeah, you could do it either way for sure.
Okay.
As long as you have, because I mean, whenever you have we didn't have ICD-10 codes on this one, but remember, anytime you have a delivery code
Mhm.
on a delivery claim, you do have to have that outcome of delivery, right? Which gives like the single live birth, multiple live births, whatever it is. So
Okay.
that would be support.
Okay.
Some insurance companies might try to say no, but you can fight it for sure. But most of them will go ahead and pay for, if you have triplets, 2 vaginal deliveries and a global C-section package.
Okay.
Yeah, just make sure you have as much support on your claim as possible with your multiple gestations and things. And usually there's not too many. I don't want to say never, but usually there's not too many things that you have to fight with multiple gestations unless they're all C-section. And there was a lot of work that went into it for whatever reason.
Okay.
Okay. Good questions. Good conversation. Like I said, pregnancy is always one of those that either you hate it or it's you finally get the hang of it and you're good. Okay. Let's do this last one really quickly. So let's do this one from a process of elimination standpoint. So we have a woman with abdominal pain and bleeding and has a diagnosis of multiple fibroid tumors and undergoes your laparoscopic resection without hysterectomy. After the abdomen is entered and inspected, it is found that she has 5 separate intramural fibroid tumors, and those tumors are removed successfully with a total weight of 300 grams. Your pathology confirms that it's a leiomyoma as well as myomas or fibroids. So what are our CPT or what are our CPT and ICD-10 codes? So from a testing perspective, we can do process of elimination in both ways. We can do, oh no, we can't. Sorry, I was reading this as 58146 instead of 585. So I would take D25.1 or D25.9 and figure out which one we should do so that we can rule out 2. And since they're close together, you can just kind of look at them at the same time. So D25.1 is an intramural leiomyoma of the uterus. And then your D25.9 is a leiomyoma of the uterus, unspecified. So what do we think? Should it be D25.1 or should it be D25.9?
D25.1.
Yep. D25.1 because it specifies here that we have 5 separate intramural fibroid tumors. So that's going to be our D25.1 because our code description specifies intramural. Okay. So we know it is not going to be A or D. So we either need to decide CPT wise, is it 58545 or 58546? I always like it when they're pretty close to each other. So that way you don't have to do a whole lot of searching and you can just look up and down. So 585. My brain is playing tricks on numbers on me too, as well as letters. 5. Okay, so 58545 is laparoscopy, surgical, myomectomy, excision, 1 to 4 intramural myomas with a total weight of 250 grams or less, and or removal of cervix myomas. And then 58546 is the same surgical, laparoscopy, myomectomy, excision, 5 or more intramural myomas, and or intramural myomas with a total weight greater than 250. So we had 5 separate and a total weight of over 300 pounds or 300 grams, not pounds. That would be a lot, right? So we need 58546. Yep. Okay. How do y'all feel about 50,000? Any questions? Anything you want to chat about for a couple minutes?
I have a question back on number 8
Okay.
with regards to the quadrant pane. For
Okay.
answer B, it said below in the notes that you would add a 50 modifier if it was bilateral, but since this wasn't bilateral, if it was real world, would you add an LT for left on this since it was
You
the
could.
left?
Yeah. It wouldn't be inappropriate to code it. Yeah. Well, actually, hang on.
Okay.
Let me double check. Let me go back and read the code description before before we decide to put that in stone. 58661. I just want to make sure that I'm telling you right with 58, and I keep going to 58561 instead of 58661. Laparoscopy surgical with the removal of adnexal structures, partial or total oophorectomy. Yeah, I would say you could put an LT. Let me
Okay.
look at select coder real quick and see if it tells me yes or no. I can give you an answer in like 2 seconds. 58661. Yeah, you can. You can put an LTRT on it.
Okay, great. Thank you.
You're welcome. That was a good question. Any other questions? Anything else you guys want to chat about? Okay. Well, I am. Oh, go ahead.
Hi, sorry. I was wondering, when is the next Zoom meeting gonna be?
It'll be next Wednesday. So they're always on Wednesdays. Unless for some reason I do have to reschedule, but if I do have to reschedule, everybody will know in advance. So they're always on Wednesdays unless they are specified another day of the week.
Okay, and I was wondering, do you think I could have these questions to work on?
Yes, they are. Are you in the Discord channel?
Yes.
Okay, if you're in the Discord channel, if you click on the meeting schedule and files channel, and then up
Okay.
at the top, there is a threads button. It looks like a little spool of thread. If you click
Okay.
on that, then it has files for the weekly study group in there. And then there's a link to the Google Drive where all of the questions are found. And then the recordings are also uploaded in there, but they're also uploaded onto YouTube as well.
Okay. Okay, sounds good.
Okay.
Thank you.
All right. You're very welcome. Absolutely. So next week we will cover 60,000. So it's going to include endocrine. We'll probably split it up in 2 weeks again. But it'll be 60,000 is going to be endocrine, nervous, and then eyes and ears as well. So I will probably, like I said, split it up into 2 and do nervous next week, nervous and endocrine next week, and then do eyes and ears in 2 weeks. Does that sound like a plan? And I will get those questions posted in the next couple of days. Hopefully, if my life decides to calm down, I will get those posted at least by no later than Monday. My goal is to get them done on Sunday, but it will be no later than Monday that I'll get them in there. Thanks, Dana, for posting those the links to that Google Drive. So if you want to, Tansy, if you want to just kind of open that and bookmark it, they're always in that Google Drive folder. All right. Well, thanks for joining us tonight.
Sorry, can you repeat? Can you
Yeah, go
repeat
ahead.
where I found this questions? I can't find it in the meeting plans.
If you click on the chat, then Dana has actually put in the link to the Google Drive. So if you're not able to find that threads, then if you go into, like I said, the chat within the meeting now within Zoom, then that is in there.
Okay.
Okay.
Thank you.
You're very welcome. You all have a good rest of your evening. Stay cool because I
Thank
know
you.
we're kind of under this big heat wave at the moment. So stay cool, and I will chat with everyone next week if I don't chat with you sooner. Thank you.
Alright,
Y'all
thank
have a good
Tiffany.
night.
you.
Uh,